All right. So this, RJ, first of all, let me congratulate you on putting together this program. It's really a wonderful effort, and thank you so much for the invitation. This exchange of knowledge is absolutely critical for any condition, but more importantly for this type of pathologies where really what we see is very piecemeal at other than very large institutions such as the one in China you just mentioned. So this patient is a 39-year-old female who came to me by the end of 2020. Previously healthy, she used to work out on a regular basis, and presented with a month history of worsening functional class. And she decided to visit a cardiologist or see a cardiologist in her hometown, which is a secondary city south of Bogota, because her husband actually noticed that she was not really in as good a shape as she had been before, and couldn't keep up with her daily tennis routine. And what the cardiologist found was a LV inflow and outflow obstruction causing severe mitral valve stenosis and aortic valve stenosis, which really was an LV outflow obstruction with this transthoracic echo on arrival. So with that echo, they called me up. She got on a plane and rushed to our hospital where we did this study.
Okay, Dr. Lestucci, what do you think about that? In Bogota, in south of Bogota, is she in a rural area? Or is it sounds like if she's playing tennis, she's not in such a rural area?
Not so much as a small secondary city, RJ.
Yeah.
But with no large.
Oh, you're cutting up, Dr. Lestucci. Hopefully she'll get back online. Patrick, what would you think about that?
I'm not specifically trained to do echocardiography, but I would assume we might look at the same entity, or we might look at two different entities. We might look at something that is mobile.
Okay, can you say this is in a short time?
I shut up, no worries. Go ahead, please.
You were cutting in and out, Chiara.
Maybe.
I'd really like to see what she says, because I was going to ask her, could this be rheumatic disease on the mitral valve? Acute rheumatic disease. Wow, look at that. That doesn't look like rheumatic disease, does it?
No, not really. Not really.
Rheumatic disease can cause thickening of the leaflets like that. Acute rheumatic fever can cause that, I think. But that's a big lump. And that's what I was curious to see. I was going to try to test her to see what she said.
Let's see if we can get her back on the line. In the meantime, I'll continue to show you the images. But what was striking, and we'll go back as soon as Dr. Lestucci comes back on, is that this patient had a transmitral gradient of 22 millimeters of mercury. It was to me, it was amazing that she was able to walk to the airport. And here you have another image showing the compromise of the posterior mitral leaflet and the posterior ventricular, the posterior LV wall, and an aortic valve gradient with a peak of 60 and a mean gradient of 40.
Wow.
So she really was very sick, didn't show it, but was really a dramatic presentation. And of course, they were extremely concerned when they looked at the echo, and when her cardiologist showed them the echo. Again, no previous history of anything. She was absolutely healthy, 2 young children, and she lived the city where she lived was approximately 600 meters above sea level, and she traveled to Bogota, which is 2,700 meters above sea level, which is about 8,500 feet, and she was slightly dyspneic, but not dramatically so.
Out of the inflow of the mitral valve at a 20 millimeter gradient, and the outflow gradient, mean gradient of the aortic valve was, what did you say, 40?
40, yeah. So she had inflow and outflow obstruction of the left ventricle, which you can see here, with clearly what appear to be two different masses. One that seemed to be attached at the apex of the left ventricle and protruding through the LV outflow tract, and occluding it at end of systole, as you can see there. And then there was a second one that was involving mostly the posterior mitral valve leaflet and extending into the posterior papillary muscle and posterior LV wall. We couldn't see anything outside the heart. She did not have a pericardial effusion and had no signs of tamponade.
I'm gonna bring Robin Jones into that question now. If and I don't know what the answer here is yet, because I don't know how the story is going to unfold. If he were to get you a biopsy and said that this was a sarcoma, transseptal biopsy, and they were able to biopsy this and said it was a sarcoma, say an intimal sarcoma or something like that, would you be willing to give somebody with these gradients this cardiac dysfunction by echo chemotherapy, neoadjuvant chemotherapy? In other words, when do you say no to neoadjuvant because the patient's too sick from a heart point of view?
So that's a great question, RJ, and I think my short answer to that would be no in this sort of situation, simply because of the drugs in the schedule that we use. And I'd be very concerned about giving combination chemotherapy preoperatively in this situation. Again, I'd sort of have a close discussion with the surgeon and with the radiologist regarding the situation, but my sort of instinctive answer would be no. Following on from that, as a general rule, even though the UK in terms of pre or post-operative chemotherapy for sarcomas is generally to not administer chemotherapy, for intimal sarcomas and cardiac sarcomas in general, we would usually administer preoperative chemotherapy.
How much do you expect the tumor to shrink with each session of chemotherapy? In other words, 3 weeks. How much would you expect? With that portion of the mitral valve, would you expect that to get better?
I think I wouldn't expect a dramatic response with one cycle if this proved to be an intimal sarcoma. And again, that would factor into the decision-making process. Having said that, I think intimal sarcomas, even though in the past the sort of dogma that they don't respond to chemotherapy, a retrospective multi-institutional study that we did showed that they did have, or they do have a relatively reasonable response rate to chemotherapy. So basically, for patients with localized disease, the response rate was 38%. So that's not not bad, but I wouldn't expect a dramatic initial response as you'd probably see with a lymphoma or some other type of tumor. And I think that would factor into the sort of decision-making process regarding neoadjuvant therapy, because I suppose if we had a very high chance of a dramatic initial response, I'd be more prepared to consider preoperative treatment.
If this were a lymphoma and the patient were in heart failure, as this patient sounds like she is mild heart failure, at least she's symptomatic from the obstructions, would you expect the lymphoma to melt away? Not totally, obviously, but it causes significant improvement in one dose, in one course?
Yes, I'd suppose there's a
You would.
yeah.
Wow.
But for sarcomas, I wouldn't expect that. I wouldn't expect that sort of initial dramatic response. Having said that, sarcomas always sort of amaze me and always do things that you don't expect. So probably now somebody's going to say, well, we treated with it was an intimal sarcoma and we treated with neoadjuvant chemotherapy and there's a dramatic initial response. So I suppose my point regarding that comment is that it's the unpredictability, I suppose, of the timing of the response and obtaining an actual response that makes it challenging with sarcomas, if that makes sense. But I'd welcome thoughts from other members of the panel as well. I always like to debate these things. So,
are there other oncologists listening that want to open the debate up a little bit, the discussion? I'm going to ask Patrick. This looks like it's from the posterior mitral annulus right at the heart. Will an MRI be able to tell us how much invasion there is of the AV groove?
Probably yes. Probably yes. MRI is excellent in snapshotting and reduction in motion if the patient is cooperative and can actually undergo the study. I think we probably would. Yeah, I would suggest if there's question regarding the invasion and the depth of invasion, I would assume that MRI might be the next reasonable step.
Yeah. Okay, Juan, we'll let you get back to it. It's a very interesting case so far.
So we took all this into consideration, of course, and we did talk to our oncologist who totally agreed with what Robin just said. And given this, the gravity of the situation and the gradients that we were seeing, and clearly the risk of progression of either one of the two obstructions, we opted to take this patient to the OR emergently that same evening, cannulated the distal ascending aorta and did a distal bicaval cannulation, planning to do an auto transplant if necessary. So we initially approached this through a left atriotomy that we extended to the roof of the left atrium without dividing or cutting the superior vena cava, and found her to have extensive tumor infiltration of the posterior mitral valve leaflet and annulus towards the posterior medial commissure mostly. And this extended into the posterior papillary muscle and posterior wall through the LV trabeculum. We proceeded to excise the mitral valve and do a subendocardial excision of the mass as far as we could, extend it into the fat without, of course, injuring the circumflex artery, which you can see in one of the images there. But needless to say, we weren't able to get a full and free margins. The second mass was a large solid mass with a pedicle that attached it to the LV apex. We were able, once we removed the the left atrial and mitral tumor, we were able to approach this through the mitral valve annulus, and we're able to resect that completely with its pedicle. And this is what we got. So you can see there on the left is the left ventricular apical mass with its point of attachment at the bottom there. The left atrial mass that extended into the posterior mitral valve leaflet, and the multiple sections of that mass that was involving the posterior LV wall, which of course we weren't able to resect, unblock. That part of the tumor was quite friable, as you can see here.
Well, Juan, did you get a coronary angiogram?
We did not. We did not get a coronary angiogram preoperatively, RJ. We probably should have. But
Did you regret it afterwards, or were you okay with it? When it's
No,
so close to the AV groove, you wonder if it's a left dominant versus right dominant system. I guess you'll know if you can't come off bypass to do some bypasses there. But
yeah, we stayed away from the circumflex, and the mass didn't seem to be extruding outside of the ventricle or into the AV groove, so we were able to stay away from it. We probably should have gotten a coronary angiogram, but again, this was her mode of presentation was so dramatic and her symptoms such that I was concerned
sure.
she would not make it through the night.
Yeah, no, I mean, obviously this patient had a very, very bad tumor. The other thing about it is that that stuff near the LVOT there, it looked like it was getting ready to break off. It's quite interesting. When you looked at this, I was expecting it to be more friable. I was expecting the posterior papillary muscle and posterior wall mass. That's what I was expecting the LV tumor to look like near the AV, near the aortic valve, but it obviously didn't. It looks totally different.
Yeah, what you can see here in the middle is this big mass here was the one that was compromising the AV groove and extending towards the left atrium. Then right here you can see the posterior mitral valve leaflet, and within this mass here is the posterior papillary muscle, which was excised completely in order to be able to get down to the base of the papillary muscle and to the LV posterior wall in order to be able to remove as much of the tumor as possible. Of course, we saw this and at that point not as a curative procedure, but more of a debulking procedure in order to be to save the patient's life, and then proceed to treat it with chemotherapy,
right.
and look for alternatives in the future.
Why did you not go through the ventricle? Was it too much, or just a little bit not what you would expect to do?
No, it seemed like we were, as we resected the endocardium and some of the trabeculae together with the posterior papillary muscle, it seemed we had a fairly clear margin, although we of course did not go as deep as you would have wanted to go. She had a small ventricle too, so the extent of the tumor would have left us with a restrictive cavity probably.
I see. Yeah, from that CT scan or the MRI, the echo that you showed us, it looked as though the AV groove was really, really involved. I'm surprised that you're able to get that much of valve out. It looked like it came through the annulus, through the AV. There. Yeah, and even the previous one. Look at that tumor there, the posterior leaflet. It looks as though it goes through the AV node. The anterior leaflet looks a little bit thickened too, I guess. But
it's this of course is a posterior, the posterior
leaflet there.
The posterior medial commissure right here, RJ. So that was fused, and you can
right
start
there.
to see the circumflex artery back here.
Yeah.
You see?
Yeah.
So we went down, went through the left atrium, resected the endocardium here, saw the fat, periarterial fat, and came down into the ventricle. I mean, she was young enough, had enough endocardium on the ventricle and the atrial side that we were able to replace that valve with a mechanical valve, and I placed a mechanical valve into her, looking for an optimal hemodynamic profile, and thinking that she was probably going to need anticoagulation postoperatively anyway, because of all the raw surfaces. The pathology on that mass was a high-grade synovial sarcoma, highly undifferentiated. So she was treated with several courses of chemotherapy by
Ask Robin what he would give. What's your next step, Robin?
Yeah, so for a young patient with a high-grade synovial sarcoma, we would give post-operative combination chemotherapy.
And when would you start, Robin?
In this setting, if she'd made a good post-operative recovery, probably within a few weeks of the operation, basically.
Like a couple of weeks.
Yeah, very promptly. Again, depending on how well she recovered from the operation, but given the aggressive nature of this, I think, and given, as Juan pointed out, the operation was done as an emergency, essentially. I would be keen to start treatment very promptly. And
would it matter? He told us, Juan, you said you think you had residual tumor left behind at the annulus level or inside the heart?
Inside the heart, in the posterior LV wall was my main concern, RJ. She was treated exactly as Robin described, and on her follow-up echo, she actually decided to visit Mike Reardon's team at Methodist and MD Anderson, where they did a transesophageal echo that showed, at the 6-month follow-up, a small mass in the left atrial wall at the interatrial septum, and that was confirmed by an MRI, and we did a PET scan as well that didn't enhance. So there was always the question as to whether this was a small laminar thrombus, as we didn't see any growth of it, and the lack of enhancement made us doubt about a recurrence of the tumor. But it was a remote area. It was a remote recurrence, if a recurrence at all. In other words, it was compromising the interatrial septum, where we had not found any tumor during the original operation. So she went to MD Anderson, underwent a few courses of chemotherapy with no regression, actually a progression in the size of the tumor, and Mike ended up operating. Oh, go ahead. I'm sorry. It's a shame that Mike is not here because it would have been.
He's supposed to be here. He must be in the operating room or something, because he's.
Yeah, I know.
So you say that there was a mass that came a few months later after she finished chemo, or during the chemo, or right from the very beginning?
After finishing chemo, we did a follow-up MRI and found that small mass that was either a thrombus or a recurrence of the tumor, but it was located at the interatrial septum, where she didn't have any tumor previously.
And you said that the MRI didn't say much, didn't give you much information.
Didn't give us much information, Robin. I'd like to hear from Robin.
I was going to ask him.
What his
and from Patrick as well. What kind of modalities we can use? Is a PET scan worthwhile here? Or Robin, both of you guys can pipe in on that.
Well, Patrick is the expert, and I've been very impressed with.
Yeah.
I will have that. I'll
The
just
thing
say.
is, there's an ask, you go to ask the radiologist, say, are you crazy? So why don't you see what you're going to ask him for and see what Patrick says in response? I think this is great.
It's very difficult to image these these anatomical areas, and particularly after surgery. And we tend to use a combination of modalities, basically. But this is really challenging, and it can be very difficult when we're giving postoperative chemotherapy to know exactly what's going on in that area. So as I say, we use a combination of techniques depending on the surgery that's been performed and the tumor type, etc. But I'm really, I'd like to sort of talk to Patrick and Juan about, the best way forward with this, because as RJ said, sometimes the radiologists go, "What are you doing? Why are you ordering these investigations?" So I'm really interested to see what you have to say.
Yeah, it's really a diagnostic dilemma in the sense that any technique we have, particularly when we look at MRI, will pose a challenge upon us, because we will have inflammatory changes, we will have some residual tumor, we will have some infiltration, we will have some scars from the previous surgery, and all the tools we use will be compromised by this effect. So post-operatively is a huge dilemma. It's such an aggressive tumor. I would agree with you. We probably would do both initially and see if there's any tumor we can detect, maybe in the cardiac CT, see if there's any outside, invading into the pericardium, maybe anything into the lung, to clear that margin. And the rest we probably would do an MRI, see what we can do if we have any clue of residual neoplasm or further, recurrence. It's going to be challenging.
These little lumps that show up after you do a cardiac resection, especially of the atrium, we don't know if it's a thickened fold or something like that.
Yes.
There's such a hard thing to deal with.
Yes.
How do you deal with those, Robin?
Yeah, good question. In the UK, we often basically just use a sequence of scans, and unless the patient is symptomatic, or if there's an obvious problem that's evolving. But often we'd have a very careful policy of just regular imaging and monitoring the situation. But again, it'd be good to hear what everybody else has to say. But often we just, if the patient's asymptomatic and there's no sort of dramatic change, then that's what we do. I mean, do you have any thoughts on Patrick and Juan and Chiara as well?
You're raising a very good point, which is serial imaging, and quite often the temporal evolution of findings is the best indicator as to what is going on. Just one snapshot alone might not give us the answer.
Right.
So unless the patient is very symptomatic. Sorry, Juan. Sorry.
No, go ahead, Robin. I was just gonna say that I totally agree, and that's what we did. So we did serial MRIs without seeing any growth. We of course assumed, given the pathology and the surgery that was performed, we had to assume that this was a recurrence of the tumor, and gave her further course of chemotherapy, with which we did not see any further growth of the mass, but it remained stable. It didn't regress either.
Did you see early growth as well, Juan?
Beg your pardon?
Was there early growth?
No.
And what
No.
interval did you use for your second CT after you found the first one?
The
3 months or 1 month or what?
Approximately 3 months, RJ.
3 months.
Yeah,
And no change with no therapy after 3 months.
No change. So she decided at that point is when they wanted to get a second opinion, and I sent her to see Mike Reardon and his team at Methodist and MD Anderson.
Robin, if there was no mass there, what kind of a prognosis would a person like this have? With a synovial sarcoma, pretty extensive synovial sarcoma with an R1 resection or an R2 resection with the early response to chemotherapy?
I would say, unfortunately, given the high-grade, undifferentiated nature of this tumor, that the prognosis is very poor. And I often prepare people, for the worst-case scenario, so that if things turn out better than planned, they're really happy. But high-grade synovial sarcoma in this location is clearly a poor prognosis tumor, unfortunately.
And would you expect this person to die of metastatic disease?
Yes, yeah. Again, local control can obviously be a problem, but
Right.
clearly there's a high chance of metastases.
And Chiara, would you consider this patient for radiotherapy? We know he went to Mike Reardon. Mike Reardon is probably going to resect it because we know Mike Reardon. But the thing is that if the patient has a poor prognosis, probably from metastatic disease, I mean, it was on the left side, it was popping in and out of her outflow tract. Would you consider doing this radiotherapy on this atrium or even the whole heart?
Unfortunately, I lost the connection.
Okay.
So I don't know the
What about,
final diagnosis.
okay, that's okay.
I saw just of the surgery, the three specimen, we was a fire. It was a sarcoma, two
It was
different tumors.
synovial sarcoma,
Oh.
synovial sarcoma.
Synovial
Federico,
sarcoma.
Federico,
Okay.
would you irradiate? Sorry, go ahead.
Yes, okay. And the margin were clean.
He thinks of possibly an R2 resection. They treated with chemotherapy. It got better. And then a few months after all the chemotherapy is finished, some mass came in the atrium distant to his resection margin, distant to his resection, in other words, in the intraatrial septum.
Okay.
And then it didn't change with time, but they gave chemotherapy anyway. And so now the question is, what would you do? Would you consider radiotherapy?
If surgery is not considered a possibility,
Then yes. So you would send for surgery.
Could try to with radiotherapy.
Okay.
Maybe because it's but it's osteosarcoma. I don't know if
Synovial sarcoma.
It's radiosensitive because not synovial sarcoma.
Synovial.
So it can be synovial. You should ask to the radiotherapist if it's likely to be radiosensitive. It could be treated. Also, anyway, it's the atrium, and an attempt can be done. It depends on the risk of surgery. I see there is Dr. Navaria.
Yes.
It's online. Can ask him if would.
So remember, this patient had a potential positive resection margin in the ventricle, now has a lesion in the atrium. So what would you consider for radiotherapy? Dr. Lestusis thinks that we should send for surgery, and that's what he had. And what do you think? Would you irradiate this? And if so, what part of the heart would you irradiate?
Good evening, everybody. I feel very honored to be here with you today. And so in synovial sarcoma is an high-grade sarcoma, and I consider chemo because it has a high metastatic potential. But if there is a potential residual margin, microscopic positive margin at surgery, I consider radiation.
And what would you irradiate? In this case, potential positive resection margin in the ventricle and now a new mass in the atrium.
I consider a neoadjuvant therapy, if possible. I don't
On the
heard
mass, on the mass, on the atrial mass, and not on the possible infiltrated margin in the ventricle, or both.
I don't understand. The mass.
We had a resection with possibly positive margin in the ventricle, and a new mass relapsed after chemotherapy in the atrium.
I consider radiation.
Yes, but on the atrium.
On the atrium, yeah.
But not the ventricle.
The mass is on the atrium. The gross.
Yeah.
Yes, I consider radiation in the atrium.
Okay. Okay, Juan, why don't you continue to let us know what happened?
So she underwent further chemotherapy, no radiation at MD Anderson, and unfortunately, the day before she was scheduled to go to surgery for re-resection, she had an intracranial bleed she had a right hemiplegia, and what's amazing about this woman is her spirit, because she actually recovered from it and was sent to a rehab facility where she recovered she was able to talk and walk and started to walk with assistance, so much so that Mike was finally able to take her to the OR last week, resecting a pedicle specimen in the that was attached to the interatrial septum. The resection margins were negative, and you can see the mass here, suspectly similar to the one Usama showed us a few minutes ago. And again, it's unfortunate that Mike is caught up in the OR, because we were waiting for the pathology report to see if it was indeed another synovial sarcoma or if it was a second primary. And she is recovering well. She is continuing her physical rehab, and from a cardiac standpoint, appears to be free from disease. Now, her workup to identify extra cardiac disease or metastatic disease has always been negative, Robin. She's never metastasized anywhere so far.
That's great news, Juan. Really, really good news. Yeah,
it's been 15 months now. So it's I mean, unfortunate but fortunate in a way.
That thing grew a lot, didn't it?
It did, and very, very quickly, RJ.
And was it the same chemo you gave her initially?
It was the same chemo, yes.
So she's failed that chemo. That would be considered failure of that chemo, right, Robin? If you grew this on that chemo, it's a failure of that chemo.
Yes, in a way, but again, I suppose at there are challenges with the interpretation of imaging, particularly in the post-operative setting. So I fully take your point, RJ, but I suppose there are always sort of caveats, but it's great that she's free of metastatic disease. Really, really good news. The bleed. So why did she have the bleed in her brain, Juan? What was the reason for that?
She was of course on anticoagulation for her mechanical valve in the mitral position, Robin. I'm not sure. It seemed to be a spontaneous bleed.
Okay.
I'm not sure if it was related to anticoagulation or the combination of anticoagulation and
the chemotherapy.
And the chemotherapy, yeah.
Yeah.
What do you
Good.
use for metastatic disease? Do you look for it with a PET scan?
Yes, that's what we usually do for metastatic disease, particularly as Juan pointed out, that there's a risk of, and I think you pointed out earlier on in your presentation, RJ, the risk of disease spreading to the brain. So for intimal sarcomas, other cardiac sarcomas, we'd use a PET CT.
How often would you do that?
So post-treatment, our policy would be to do a scan every 3 months.
For how long?
For the first 2 years, and then 6 months after that, and then annual thereafter.
Patrick, do you know what they do here?
Well, we use PET extensively for this indication. I have to admit, I don't know if the frequency is every 3 months. I wouldn't know this. That's very frequent, but probably required, given the dynamic and the biology of this neoplasm.
Yeah, for a high-grade tumor like this, we would. I fully take your point, Patrick, regarding a fairly intensive schedule, but we would do scans every 3
months. Yeah.
And isolated lesions to the brain, Robin, do you go after that, or do you irradiate those?
I suppose, again, that's sort of context dependent, depending on the exact position, depending on disease status elsewhere, and depending on the tumor type as well. But we would generally try and be fairly aggressive for an isolated lesion, yes. I.e., we would consider a surgical approach.
And Juan, what are you going to use for surveillance? Do you guys have a PET scanner in your hospital?
Yeah, we do, RJ, and we did one on her as part of the imaging sequence previously to try and see if there was uptake from that original small lesion, and there wasn't. So what we do is what we just heard, and tend to follow them with either MRI or MRI and PET, if we can follow them at our place. Otherwise, we try to bring them back as often as possible to image them from their referring institutions.
If I understand correctly, that looked like a big egg attached to the intratracheal septum. Is that what that was? It looked like that, right? I mean, you didn't do the operation, but that was my impression. Was that what actually it was? It looked like the whole surrounding thing was a tumor, right? Attached to the.
So this here is the intratracheal septum.
Yeah.
And the tumor was protruding.
Yeah, that's what it looks like.
Into the atrium,
Yeah.
and actually making the mitral valve prosthesis dysfunctional. So Mike operated with Tom McGillivray, and between the two of them, they removed the tumor, which was, according to Mike's description, fairly easy. It was just attached, pedicled and attached to the intratracheal septum, which they removed and replaced with a patch of photofixed pericardium. And they decided, due to her intracranial bleed and difficulties in her management because of the anticoagulation required by the mechanical prosthesis, they replaced the mechanical prosthesis and changed it for a tissue valve.
Yeah, that's good.